Question 1. A 48-year-old accountant presents with right wrist pain, particularly with gripping and ulnar deviation. She reports a history of repetitive keyboard use and has noticed a popping sensation over the ulnar side of her wrist. On examination, a positive fovea sign is noted. Which of the following conditions is most likely indicated by these findings? A. Extensor carpi ulnaris, ECU, subluxation. B. Triangular fibrocartilage complex, TFCC, tear. C. Ulnar impaction syndrome. D. Pisiform fracture. Answer: B. Triangular fibrocartilage complex, TFCC, tear. This question tests the understanding of common wrist pain etiologies, particularly those affecting the ulnar side, and the diagnostic significance of specific clinical tests. The keywords popping sensation over the ulnar side, pain with gripping and ulnar deviation, and especially a positive fovea sign are classic indicators of a TFCC tear. The fovea sign, pain elicited by pressing a thumb into the soft spot between the ulnar styloid and flexor carpi ulnaris tendon, is highly specific for TFCC pathology. While other conditions like ECU subluxation or ulnar impaction can cause ulnar-sided pain, the fovea sign points most directly to TFCC involvement, which is crucial for distinguishing diagnosis. When you see ulnar-sided wrist pain with a positive fovea sign, think TFCC. Question 2. A 62-year-old patient undergoes a flexor tendon repair in Zone 2. On post-operative day 3, during a passive range of motion exercise, the therapist observes signs of gapping at the repair site. What is the most appropriate immediate action for the therapist? A. Discontinue all passive range of motion exercises and initiate light active flexion. B. Immediately cease the exercise, immobilize the digit, and notify the surgeon. C. Increase the frequency of passive range of motion exercises to prevent stiffness. D. Apply a dynamic splint to facilitate controlled active flexion. Answer: B. Immediately cease the exercise, immobilize the digit, and notify the surgeon. This question assesses the critical understanding of flexor tendon repair protocols and immediate management of complications. The keywords flexor tendon repair in Zone 2, postoperative day 3, and signs of gapping are crucial, indicating a potentially compromised repair. Gapping is a serious sign of repair failure or impending rupture. The immediate priority is to protect the repair, which means ceasing all provocative motion, immobilizing the affected digit to prevent further damage, and promptly informing the surgeon for re-evaluation and potential surgical intervention. You should always prioritize the integrity of the repair over immediate range of motion when gapping is observed. Question 3. A therapist is evaluating a patient with a suspected C8 nerve root compression. Which combination of sensory and motor deficits would most strongly support this diagnosis? A. Sensory loss over the lateral forearm and weakness of elbow flexion. B. Sensory loss over the thumb and index finger and weakness of wrist extension. C. Sensory loss over the fifth digit and ulnar forearm, with weakness of finger flexion and thumb extension. D. Sensory loss over the dorsal hand and weakness of finger abduction. Answer: C. Sensory loss over the fifth digit and ulnar forearm, with weakness of finger flexion and thumb extension. This question requires precise knowledge of dermatome and myotome distribution for cervical nerve roots. The keyword C8 nerve root directs you to identify the specific sensory and motor innervation associated with this level. C8 classically supplies sensation to the fifth digit, ulnar aspect of the fourth digit, and the ulnar forearm. Motor innervation includes the flexor digitorum profundus, finger flexion, and the flexor pollicis longus, thumb IP flexion, as well as intrinsic hand muscles like abductor pollicis brevis and adductor pollicis, which also contribute to thumb movements, including opposition and adduction, which aid in powerful thumb extension. Therefore, weakness in finger flexion and thumb extension, strength of thumb IP flexion, often tested as part of C8, strongly correlates with C8 pathology. When assessing nerve root levels, remember to connect both the specific sensory and motor deficits for an accurate diagnosis. Question 4. A 25-year-old avid rock climber presents with acute pain at the A2 pulley of the left ring finger following a dynamic move. Clinical examination reveals localized tenderness and swelling. Which of the following splinting recommendations is most appropriate for initial management? A. Static finger extension splint, 0 degrees, for 4 weeks. B. Full-time dynamic traction splint for 6 weeks. C. Relative motion extension splint, example yoke splint, for 3 weeks. D. Dorsal blocking splint with MP joint flex to 70 degrees. Answer: C. Relative motion extension splint, example yoke splint, for 3 weeks. This question tests knowledge of specific splinting interventions for common climbing injuries, particularly A2 pulley tears. The keywords rock climber, A2 pulley, and acute pain are crucial, pointing towards a common injury in this population. For a pulley injury, especially a partial tear or strain, a relative motion extension splint, like a yoke splint, sometimes called an MCP extension block splint or simply a pulley protection splint, is often used to provide relative rest and protect the healing pulley while allowing limited controlled motion. This splint holds the injured finger in slight relative extension compared to adjacent fingers, reducing tension on the pulley during gripping without complete immobilization. Remember that relative motion splinting is often preferred for pulley injuries to promote healing while maintaining some motion. Question 5. A patient with severe carpal tunnel syndrome, confirmed by nerve conduction studies, is scheduled for an open carpal tunnel release. Preoperatively, the therapist educates the patient on potential complications. Which of the following complications is most specifically associated with open carpal tunnel release? A. Recurrence of median nerve compression symptoms. B. Pillar pain. C. Neuroma formation of the superficial radial nerve. D. Reflex sympathetic dystrophy, RSD, affecting the entire upper extremity. Answer: B. Pillar pain. This question focuses on specific post-operative complications related to carpal tunnel release surgery. The keyword open carpal tunnel release is important, as some complications are more common or unique to this approach. Pillar pain, characterized by pain localized to the thenar and hypothenar eminences on either side of the carpal tunnel, is a common and often temporary complication unique to both open and endoscopic carpal tunnel releases due to incision of the transverse carpal ligament and altered carpal arch mechanics. While other options like recurrence or RSD can occur with any hand surgery, pillar pain is a very specific and recognized complication directly linked to the surgical procedure itself. When discussing carpal tunnel release complications, pillar pain is a distinct and expected post-operative issue. Question 6. A 55-year-old patient presents with a long-standing history of progressive, bilateral ulnar deviation of the fingers at the MCP joints, swan neck deformities of the index and middle fingers, and boutonniere deformities of the ring and small fingers. What is the most likely diagnosis? A. Osteoarthritis. B. Psoriatic arthritis. C. Rheumatoid arthritis. D. Gout. Answer: C. Rheumatoid arthritis. This question tests the ability to recognize classic hand deformities associated with systemic inflammatory conditions. The keywords long-standing history, progressive, bilateral ulnar deviation of the fingers at the MCP joints, swan neck deformities, and boutonniere deformities are highly characteristic of rheumatoid arthritis. These deformities result from chronic inflammation of the synovium, leading to ligamentous laxity, tendon imbalances, and joint destruction. While other arthritic conditions can affect the hand, this specific combination of deformities, particularly bilateral MCP ulnar drift, is the hallmark presentation of rheumatoid hand involvement. When you see this cluster of specific deformities, immediately consider rheumatoid arthritis as the primary diagnosis. Question 7. A therapist is instructing a patient with lateral epicondylosis on proper ergonomic setup for computer use. Which of the following recommendations is most crucial to reduce strain on the wrist extensors? A. Positioning the monitor directly in front of the user at eye level. B. Ensuring the keyboard is angled upward to promote wrist extension. C. Maintaining a neutral wrist position while typing, with forearms supported. D. Using a vertical mouse to encourage wrist pronation. Answer: C. Maintaining a neutral wrist position while typing, with forearms supported. This question assesses the understanding of ergonomic principles specifically for managing lateral epicondylosis, tennis elbow. The keywords lateral epicondylosis and reduce strain on the wrist extensors are key, as lateral epicondylosis is an overuse injury involving the common extensor origin, often exacerbated by repetitive wrist extension or gripping with an extended wrist. Maintaining a neutral wrist position minimizes the activation and load on the wrist extensors, which are already inflamed. Supporting the forearms further reduces static muscle contraction required to hold the arms up, thereby decreasing overall strain on the elbow extensors. Ergonomic modifications for lateral epicondylosis should always prioritize neutral wrist posture to protect the extensor muscles. Question 8. A patient is referred for hand therapy following a replantation of the dominant thumb. The patient is 3 weeks post-surgery. Which of the following interventions is contraindicated at this stage? A. Gentle active range of motion of the wrist and unaffected digits. B. Application of moist heat to the replanted thumb to promote circulation. C. Scar massage to the incision site once the wound is fully closed. D. Patient education on sharp/dull discrimination sensory re-education. Answer: B. Application of moist heat to the replanted thumb to promote circulation. This question evaluates the understanding of critical post-replantation care, particularly concerning vascular integrity. The keywords replantation of the dominant thumb and 3 weeks post-surgery are vital. While heat can improve circulation, applying direct heat to a replanted digit in the early stages, typically up to 6 to 8 weeks, sometimes longer depending on vascular status, is contraindicated. Replanted tissues have compromised sensation and temperature regulation, making them highly susceptible to thermal injury. Additionally, vasodilation from heat can lead to excessive edema and potentially increase venous congestion or arterial steal, jeopardizing the delicate vascular anastomosis. Always err on the side of caution with heat in early replantation, as protecting vascular integrity is paramount. Question 9. A therapist is evaluating a patient with a chronic mallet finger deformity that has failed conservative splinting. The patient exhibits a fixed dip joint extension lag of 30 degrees, and the patient has good passive dip extension. Which surgical option is most appropriate for this type of mallet finger? A. Dip joint fusion. B. Extensor tendon tenotomy at the dip joint. C. Arthrodesis of the PIP joint. D. Extensor tendon advancement or reconstruction at the dip joint. Answer: D. Extensor tendon advancement or reconstruction at the dip joint. This question tests the understanding of surgical management options for mallet finger deformities, specifically when conservative measures fail. The keywords chronic mallet finger deformity, failed conservative splinting, fixed dip joint extension lag of 30 degrees, and good passive dip extension are crucial. The presence of a fixed extension lag but good passive motion suggests that the extensor tendon is lengthened or disrupted, but the joint itself is still mobile. In such cases, surgical repair or reconstruction, advancement, of the extensor tendon at the dip joint is indicated to restore active extension. Arthrodesis, fusion, is typically reserved for severe, painful, arthritic joints or when reconstruction is not feasible, while tenotomy is for flexion contractures. The key here is good passive range of motion. Question 10. A patient presents with acute wrist pain after falling onto an outstretched hand. Radiographs show a fracture of the distal radius with dorsal displacement and comminution, consistent with a Cole's fracture. Which associated injury should the therapist be particularly vigilant for during initial assessment? A. Scaphoid fracture. B. Lunate dislocation. C. Median nerve compression. D. Extensor pollicis longus, EPL, rupture. Answer: C. Median nerve compression. This question asks about common associated injuries with distal radius fractures, specifically a Cole's fracture. The keywords Cole's fracture and dorsal displacement and comminution are key. Cole's fractures, especially those with significant displacement, can cause acute swelling and hematoma formation within the carpal tunnel, leading to compression of the median nerve. This can manifest as acute carpal tunnel syndrome, presenting with paresthesias in the thumb, index, middle, and radial half of the ring finger, or even motor weakness. While other injuries can occur, acute median nerve compression is a critical and time-sensitive complication that requires immediate attention. Always assess for neurological deficits, particularly median nerve function, following a distal radius fracture. Question 11. A 40-year-old patient with a 15-year history of insulin-dependent diabetes mellitus presents with progressive, painless thickening and contracture of the palmar fascia, particularly affecting the ring and small fingers. There are palpable cords extending from the palm into the digits. What is the most appropriate long-term prognosis for this condition? A. It will spontaneously resolve over time without intervention. B. It is unlikely to progress further, especially with activity modification. C. It is a progressive condition that often requires surgical or enzymatic intervention for functional improvement. D. It is a benign condition that typically responds well to steroid injections and splinting. Answer: C. It is a progressive condition that often requires surgical or enzymatic intervention for functional improvement. This question describes the classic presentation of Dupuytren's contracture, often associated with diabetes. The keywords progressive, painless thickening and contracture of the palmar fascia, palpable cords, and ring and small fingers are diagnostic. Dupuytren's contracture is an insidious, progressive fibrotic disorder where the palmar fascia thickens and shortens, causing flexion contractures of the MCP and PIP joints. It does not spontaneously resolve, nor does it typically respond to conservative treatments like splinting or steroid injections for advanced stages. Surgical fasciectomy or enzymatic fasciotomy are the primary treatments to release the contractures and restore digital extension. Dupuytren's is a progressive disease that usually requires intervention when functional deficits arise. Question 12. A patient with a radial nerve palsy, sustained from a humeral shaft fracture, is being fitted with a dynamic wrist extension splint. The primary purpose of this splint is to A. Prevent elbow flexion contracture and promote nerve regeneration. B. Maximize grip strength and facilitate wrist supination. C. Provide passive wrist and digit extension, and allow active finger flexion. D. Immobilize the wrist and hand to prevent further nerve damage. Answer: C. Provide passive wrist and digit extension, and allow active finger flexion. This question asks about the primary function of a common orthosis for radial nerve palsy. The keywords radial nerve palsy and dynamic wrist extension splint are critical. Radial nerve palsy typically results in weakness or paralysis of the wrist, finger, and thumb extensors, wrist drop. A dynamic wrist extension splint, example low-profile dynamic radial nerve splint, is designed to passively hold the wrist and digits in extension, preventing contractures and overstretching of the denervated extensors. Crucially, its dynamic nature allows the patient to actively flex their fingers and thumb into the palm against the elastic resistance, which facilitates functional grasp. The splint supports the wrist for optimal hand function while waiting for nerve recovery. Question 13. A 30-year-old office worker reports insidious onset of numbness and tingling in the fourth and fifth fingers, primarily at night. She occasionally feels her grip strength is weak. On examination, the therapist notes atrophy of the hypothenar eminence and positive Tinel sign at the elbow, but a negative Froment sign. Which of the following is the most likely site of compression? A. Guyon's canal. B. Arcade of Struthers. C. Cubital tunnel. D. Thoracic outlet. Answer: C. Cubital tunnel. This question requires differentiation between various sites of ulnar nerve compression. The keywords numbness and tingling in the fourth and fifth fingers, atrophy of the hypothenar eminence, and positive Tinel sign at the elbow strongly point to cubital tunnel syndrome. Numbness in the ulnar two digits and hypothenar atrophy are classic signs of ulnar nerve involvement. A positive Tinel's at the elbow further localizes the compression to the cubital tunnel. While Guyon's canal can cause sensory deficits in the ulnar digits and intrinsic weakness, hypothenar atrophy is less common, often spared if compression is distal to the hypothenar branch, and Tinel's at the elbow wouldn't be primary. The absence of a Froment sign suggests that adductor pollicis weakness, a late and severe sign of ulnar nerve palsy, is not yet present. The combination of symptoms and signs points clearly to the cubital tunnel. Question 14. A patient with a repaired central slip rupture at the PIP joint, boutonniere deformity surgical repair, is referred for therapy. What is the most critical initial intervention for maintaining the repair and preventing recurrence of the deformity? A. Gentle active flexion exercises of the PIP joint to 30 degrees. B. Static progressive splinting of the PIP joint into flexion. C. Immobilization of the PIP joint in full extension, allowing dip and MCP motion. D. Aggressive passive range of motion to prevent stiffness. Answer: C. Immobilization of the PIP joint in full extension, allowing dip and MCP motion. This question focuses on critical post-operative management for a central slip repair, aiming to prevent boutonniere deformity. The keywords repaired central slip rupture and preventing recurrence of the deformity are crucial. The central slip extends the PIP joint. After repair, the PIP joint must be held in full extension, typically for 6 to 8 weeks, to allow the tendon to heal without tension. Allowing active or passive flexion at the PIP joint too early would place stress on the delicate repair and risk rupture or lengthening, leading to a recurrent boutonniere deformity, PIP flexion, dip hyperextension. Distal and proximal joints, like the dip and MCP, are typically allowed motion to prevent stiffness. Maintaining PIP extension is paramount for central slip healing. Question 15. A patient with de Quervain's tenosynovitis reports increased pain and swelling after engaging in self-stretching exercises. Which of the following stretching techniques was most likely performed incorrectly or excessively to exacerbate their symptoms? A. Wrist extension with fingers flexed. B. Thumb flexion and adduction across the palm. C. Ulnar deviation of the wrist with the thumb flexed into the palm, Finkelstein's maneuver. D. Wrist radial deviation with forearm pronation. Answer: C. Ulnar deviation of the wrist with the thumb flexed into the palm, Finkelstein's maneuver. This question assesses knowledge of de Quervain's tenosynovitis and positions that provoke it. The keywords de Quervain's tenosynovitis and increased pain and swelling are key. De Quervain's involves inflammation of the abductor pollicis longus, APL, and extensor pollicis brevis, EPB, tendons within the first dorsal compartment. The Finkelstein's maneuver, which involves grasping the thumb into the palm and then ulnar deviating the wrist, is a classic provocative test for this condition because it stretches these specific tendons. Therefore, attempting to use this movement as a self-stretch would exacerbate inflammation and pain in a patient with de Quervain's. Avoid any movement that directly stretches or compresses the inflamed tendons in the first dorsal compartment. Question 16. A patient with a complete rupture of the flexor pollicis longus, FPL, tendon in zone 1, distal to I2 pulley, undergoes a direct primary repair. Which of the following post-operative splinting positions is most appropriate immediately following surgery? A. Wrist in neutral, MCPs in 90 degrees flexion, IPs in full extension. B. Wrist in 30 degrees flexion, MCPs in 60 degrees flexion, IP joints in full extension. C. Wrist in 45 degrees extension, MCPs in 0 degrees, IP joints in full extension. D. Wrist in neutral, thumb IP joint in 10 to 15 degrees flexion, thumb MP joint in 0 to 5 degrees flexion, CMC in abduction. Answer: D. Wrist in neutral, thumb IP joint in 10 to 15 degrees flexion, thumb MP joint in 0 to 5 degrees flexion, CMC in abduction. This question tests specific splinting protocols for FPL tendon repairs. The keywords complete rupture of the flexor pollicis longus, FPL, tendon, zone 1, and primary repair are critical. For an FPL repair, the goal of postoperative splinting is to protect the repair by placing the thumb in a position that reduces tension on the repaired tendon while allowing for potential early motion protocols. This involves maintaining the wrist in neutral or slight flexion, the thumb CMC joint in abduction, the thumb MP joint in slight flexion, 0 to 5 degrees, and the thumb IP joint in slight flexion, 10 to 15 degrees. This specific position minimizes stretch on the FPL and promotes healing. Precise positioning of each joint is vital for tendon repair protection. Question 17. A therapist is treating a patient with a chronic dorsal wrist ganglion. The patient reports intermittent pain and limited wrist extension. Which of the following is the most effective long-term non-surgical intervention for this condition? A. Immobilization with a wrist splint to reduce cyst size. B. Frequent deep tissue massage over the ganglion. C. Aspiration and steroid injection. D. Education on activity modification to avoid repetitive wrist extension. Answer: D. Education on activity modification to avoid repetitive wrist extension. This question addresses the long-term management of dorsal wrist ganglia. The keywords chronic dorsal wrist ganglion, intermittent pain, and limited wrist extension point to a symptomatic ganglion. While aspiration and injection can temporarily reduce symptoms, ganglia often recur. Long-term non-surgical management focuses on reducing irritation and promoting spontaneous resolution or symptom control. Education on activity modification, especially avoiding repetitive wrist extension or compression, helps decrease fluid production and irritation of the underlying joint capsule or tendon sheath, which are often the sources of the ganglion. Emphasize activity modification and ergonomic adjustments for sustained relief from ganglion symptoms. Question 18. A 50-year-old patient presents with pain and stiffness in the dominant hand, particularly at the base of the thumb. She reports difficulty with pinch activities like opening jars. On examination, a positive grind test is noted, and radiographs show narrowing of the joint space at the CMC joint. What is the most appropriate initial splinting recommendation? A. Long arm resting splint. B. MCP joint immobilization splint. C. Thumb spica splint with CMC joint positioned in abduction and slight flexion. D. Dynamic extension splint for the thumb. Answer: C. Thumb spica splint with CMC joint positioned in abduction and slight flexion. This question describes the classic presentation of CMC joint osteoarthritis. The keywords pain and stiffness at the base of the thumb, difficulty with pinch activities, and positive grind test strongly indicate CMC joint OA. A thumb spica splint is the most appropriate initial intervention. It provides rest and support to the arthritic CMC joint by immobilizing it while allowing for pinch and grasp activities with other fingers. Positioning the CMC joint in abduction and slight flexion helps maintain the joint space, reduce subluxation, and decrease pressure on the degenerated cartilage. Splinting the CMC joint in a resting or functional position is a cornerstone of conservative management for thumb base arthritis. Question 19. A patient is prescribed a static progressive elbow extension splint following a severe elbow fracture with significant flexion contracture. When instructing the patient on home use, what is the most important factor to emphasize regarding wearing schedule and tension adjustment? A. Apply maximum tension immediately to achieve the fastest gain in extension. B. Wear the splint intermittently for 30 minutes, 3 times a day. C. Apply low load, prolonged stretch by gradually increasing tension, aiming for tolerable discomfort. D. Only wear the splint during therapeutic exercise sessions, not for prolonged periods. Answer: C. Apply low load, prolonged stretch by gradually increasing tension, aiming for tolerable discomfort. This question addresses the fundamental principle behind static progressive splinting for contracture management. The keywords static progressive elbow extension splint and significant flexion contracture are crucial. The principle of static progressive splinting is to apply a low load, prolonged stretch to soft tissues over time. This involves gradually increasing the tension or angle of the splint to maintain a comfortable but effective stretch. The aim is tissue elongation through creep, rather than rapid, high-intensity stretching which can cause inflammation, pain, or tissue damage. Patients should be taught to adjust the tension only to a point of tolerable discomfort. For contractures, prioritize consistent, low-load, prolonged stretching for effective tissue remodeling. Question 20. A therapist is performing manual muscle testing, MMT, for the flexor digitorum profundus, FDP, to the index finger. Which specific action should the patient be asked to perform while the therapist stabilizes the proximal phalanx? A. Flex the metacarpophalangeal, MCP, joint. B. Flex the proximal interphalangeal, PIP, joint. C. Flex the distal interphalangeal, DIP, joint. D. Extend the distal interphalangeal, DIP, joint. Answer: C. Flex the distal interphalangeal, DIP, joint. This question tests the precise knowledge of manual muscle testing for individual finger flexors. The keywords manual muscle testing, MMT, flexor digitorum profundus, FDP, and index finger are vital. The FDP is the sole muscle responsible for flexing the distal interphalangeal, DIP, joint of the fingers. To isolate its action during MMT, the therapist must stabilize the proximal phalanx and the PIP joint, preventing movement at these more proximal joints. This allows the patient to attempt only DIP joint flexion against resistance, thereby ensuring accurate assessment of FDP strength. Always isolate the action of the specific muscle being tested for accurate MMT. Question 21. A patient presents with a laceration to the dorsal aspect of the hand over the index finger, resulting in a complete rupture of the extensor digitorum communis, EDC, tendon to the index finger proximal to the MCP joint. Which of the following deformities would be most evident at rest? A. Flexion posture of the PIP joint. B. Hyperextension of the DIP joint. C. Flexion posture of the MCP joint. D. Ulnar deviation of the MCP joint. Answer: C. Flexion posture of the MCP joint. This question assesses the understanding of extensor tendon anatomy and the resulting posture following a rupture. The keywords laceration to the dorsal aspect, complete rupture of the extensor digitorum communis, EDC, tendon, and proximal to the MCP joint are critical. The EDC tendon is responsible for extending the MCP joints. If the EDC tendon to the index finger is ruptured proximal to the MCP joint, the patient will lose the ability to actively extend that MCP joint. At rest, the MCP joint will assume a flexion posture due to the unopposed pull of the intrinsic muscles and flexor tendons. An extensor tendon rupture proximal to the MCP will always result in an MCP flexion lag. Question 22. A patient with a radial head fracture, treated non-operatively, is experiencing continued elbow stiffness and pain primarily with forearm rotation, supination and pronation. Her elbow flexion/extension is within functional limits. Which of the following modalities would be most appropriate to address her primary complaint? A. High-intensity ultrasound over the lateral epicondyle. B. Superficial heat pack with passive range of motion. C. Low-load, long-duration splinting targeting forearm rotation. D. Transcutaneous electrical nerve stimulation, TENS, for pain management. Answer: C. Low-load, long-duration splinting targeting forearm rotation. This question focuses on appropriate interventions for specific post-fracture stiffness patterns. The keywords radial head fracture, continued elbow stiffness, and pain primarily with forearm rotation, supination and pronation are crucial. While general modalities might help with pain or stiffness, the specific limitation in forearm rotation suggests capsular or soft tissue tightness restricting the radioulnar joints. Low-load, long-duration splinting, such as a static progressive rotation splint, is highly effective for addressing specific capsular tightness and improving range of motion. Superficial heat might precede stretching, but it's not the primary intervention for gaining range. Ultrasound is generally for soft tissue healing or pain, and TENS is solely for pain relief. For persistent joint stiffness, consider a focused splinting program. Question 23. A therapist is evaluating a patient with a suspected ulnar collateral ligament, UCL, tear of the thumb MCP joint, skier's/gamekeeper's thumb. Which specific clinical finding would indicate a complete rupture, Stener lesion? A. Pain and instability with valgus stress testing of the MCP joint. B. Palpable mass proximal to the adductor aponeurosis. C. Increased laxity with valgus stress when the MCP joint is in 30 degrees of flexion. D. Absence of a palpable ligament on the ulnar aspect of the thumb MCP joint. Answer: B. Palpable mass proximal to the adductor aponeurosis. This question assesses the ability to differentiate between a partial and complete UCL tear of the thumb MCP joint, specifically identifying a Stener lesion. The keywords ulnar collateral ligament, UCL, tear, skier's/gamekeeper's thumb, and Stener lesion are essential. A Stener lesion occurs when the avulsed distal end of the UCL displaces superficial and proximal to the adductor aponeurosis, preventing reduction and healing. The inability to palpate the ligament in its usual anatomical position, and instead feeling a firm, palpable mass, the avulsed ligament, proximal to the adductor aponeurosis, is a clinical sign highly indicative of a Stener lesion. A Stener lesion necessitates surgical repair due to its inability to heal spontaneously. Question 24. A 60-year-old patient reports burning pain and paresthesias along the radial aspect of the wrist and dorsal thumb following prolonged wrist immobilization in a cast. There are no motor deficits. Palpation reveals tenderness over the distal radius. Which nerve is most likely entrapped? A. Anterior interosseous nerve. B. Posterior interosseous nerve. C. Superficial radial nerve. D. Median nerve. Answer: C. Superficial radial nerve. This question tests knowledge of nerve entrapment syndromes, specifically relating to cast compression. The keywords burning pain and paresthesias, radial aspect of the wrist and dorsal thumb, prolonged wrist immobilization in a cast, and no motor deficits are highly indicative of superficial radial nerve entrapment, also known as Wartenberg's syndrome or chiralgia paresthetica. This sensory-only nerve is vulnerable to compression or irritation, often by tight wristbands, handcuffs, or, as in this case, prolonged external pressure from a cast. The lack of motor deficits helps differentiate it from anterior or posterior interosseous syndromes, which primarily cause motor weakness. Anytime you see pure sensory symptoms on the radial aspect of the hand with a history of compression, consider the superficial radial nerve. Question 25. A 35-year-old patient with a distal radius fracture, currently in a short arm cast, reports significant swelling and pain that is disproportionate to the injury, unrelieved by elevation and pain medication. She also describes a tight, burning sensation and progressive numbness in her fingers. Passive stretching of the fingers causes severe pain. What is the most immediate concern? A. Delayed union of the fracture. B. Peripheral nerve laceration. C. Acute compartment syndrome. D. Complex regional pain syndrome, CRPS, type 1. Answer: C. Acute compartment syndrome. This question presents a classic scenario for a medical emergency in hand therapy. The keywords distal radius fracture, significant swelling and pain disproportionate to the injury, unrelieved by elevation and pain medication, tight, burning sensation, progressive numbness, and passive stretching of the fingers causes severe pain are all cardinal signs of acute compartment syndrome. This condition occurs when increased pressure within a confined facial compartment compromises circulation and nerve function, posing a risk of irreversible muscle ischemia and nerve damage. It requires immediate medical attention, typically a fasciotomy. While CRPS can develop, its onset is usually later, and the tightness and severe pain with passive stretch are more indicative of acute compartment pressure. Recognize the 6 Ps of compartment syndrome: pain, pallor, paresthesias, pulselessness, paralysis, and poikilothermia, with pain being the most reliable early symptom.